Good morning and welcome to the 2021 Scholars Day program. There will be Q&A after each presentation. If you would like to submit a question for the panelists, please do so in the Q&A panel. This session is being recorded. Thank you.
Good morning, everyone. My name is Lois Sadler, and I'd like to welcome everyone to the first ever YSN Virtual Scholars Day Conference. On behalf of our planning group, Tish Knopf, Joan Kearney, Marianne Camilleri, Lorena Fonte, and myself, we would like to thank our keynote speaker and all of the fellows and students who submitted abstracts for the presentations and posters for today. We would like to give a special acknowledgement and thank you to Lorena Fonte, who has worked tirelessly in organizing, managing, and co-producing this virtual meeting. Before I introduce Dean Ann Kirth, I will quickly run through today's program agenda. First, Dean Kirth will give welcoming remarks, followed by our keynote speaker, Dr. Nelson. After the keynote presentation, there will be a short coffee break, followed by the presentations from our 4 YSN scholars. At the end of the scholars' presentations, Dr. Kearney will have closing remarks and an invitation for all attendees to view the virtual posters. Now, it is my pleasure to introduce the Yale School of Nursing Dean, Dr. Ann Kirth. Thank you.
Thanks so much, Lois, and welcome everybody. We're not gathering at the building here in West Campus, as you see behind me. It is virtual, but it's always inspiring to have this session, to see the scholarship of our brilliant students supported by their faculty. And I think particularly in this year, this is a year where the importance of science and evidence has been so crucial. We've seen it accelerate care in COVID, also point out the health disparities and syndemics, and demonstrating how nursing addresses all of these issues and our scholarship can help heal. I'll just note that the importance of doctoral preparation in nursing really can't be overstated. You're going to be the leaders and change agents, scientists, and faculty of the future right here. It's encouraging, I would also point out, that the Institute of Medicine, National Academy of Medicine Future of Nursing original goal to double nurses in the United States with doctoral preparation by 2020 was in fact achieved. There are now 38,000 doctorally prepared nurses in the United States. Addressing the needs of vulnerable populations has been a longstanding theme at YSN. We've made the aspiration of better health equity our focus. And I would just say it's nice to note that our colleagues in medicine are now also doing the same. So they changed their mission statement in fall 2020 to echo our own. They're saying we commit to improving the health of all people. Creating and applying an evidence base to do that is really fundamental. And so we're really pleased to showcase this creativity and progress of our YSN doctoral scholars. It's an uplifting spring tradition that continues virtually today. So I'm also very honored to introduce our keynote speaker, Dr. LaRon Nelson, who is the Independence Foundation Associate Professor of Nursing and Associate Dean of Global Affairs and Planetary Health at YSN. He's also co-director of the Research Education Initiative for Diverse Scholars, the READS Fellowship Program at the Yale Center for Interdisciplinary Research on AIDS. Professor Nelson also is the current holder of the OHTN Research Chair in Implementation Science with Black Communities, which is based at St. Michael's Hospital in Toronto. He's received numerous accolades and honors, all well-deserved, including a Canadian Rising Star in Global Health, the Excellence in HIV Prevention Award by the Association of Nurses in AIDS Care, and the President's Trailblazer Award by the National Black Nurses Association. He serves on the editorial board of the Journal of Urban Health, is an associate editor for the Journal of Adolescent Health, and an associate editor for the Global Health section of BMC Public Health, because he's not busy enough. Professor Nelson has active research projects in the United States, Canada, and Ghana, and his research has been funded by the National Institutes of Health, the Centers for Disease Control and Prevention, the Canadian Institute for Health Research, Grand Challenges Canada, and the Ontario HIV Treatment Network. We're really grateful to have him present his talk today. Dr. Nelson.
Great. Thank you, Dean Kirth, for the introduction, and thank you for the invitation to present at Scholars Day. Today I'm going to talk about this topic titled The Complexities of Care Towards Multi-Level Interventions to Promote Health Equity. And as Dean Kirth just described to you, health equity has really come into sharp focus, I think, nationally in the last few years, but it's really been a central feature of the work that that YSN has become known for many years. So I'll talk about this topic in the context of the research that I do in the United States in particular, and that is focused on HIV among Black men who have sex with other men, a group that is experiencing this inequities in HIV infection and is in many ways socially marginalized. So this, what you see here is a map of the United States, and it is showing the rates of HIV prevalence across the country. This is data from CDC, and it is showing that at the end of 2018, there was about 1.2 million Americans who had HIV, but of those, about 250,000 were Black, gay, or bisexual men. If you notice the color scheme, the darker the red, or the deeper the red, however you want to think about it, shows a higher rate per 100,000. And the darkest, sort of deepest red is greater than 381 cases per 100,000 of HIV. And you'll notice that the deepest red sort of takes a line across the US South from about Washington, DC, down through Florida and across through the eastern part of Texas. It's a pattern, it's a similar pattern if anyone's been paying attention to what we've seen in disparities around COVID, for example. So this is just as a start that Black men who have sex with men have disproportionate rate of HIV infection. More of them are living with HIV as a proportion of their population. This next slide here is showing same map of the United States, but this is looking at new cases of HIV incidents. And in that same time period, 2018, there were about 40,000 new HIV diagnoses in the US. But most of those, the majority of those, 51% were actually in the US South. And the deeper blue pattern, as you can notice, is also across that same sort of line across South, down the Eastern Seaboard, across the Gulf Coast to Texas. And of those 40,000 new HIV diagnoses in 2018, a quarter of those were among Black, gay, and bisexual men. The chart that you see to the right of your screen is showing the estimated incidence over time among men who have sex with men between 2010 and 2018. What you'll see is that even in 2010, the rate of new infections among Black men compared to white men were higher. But over time, you'll see that the rates among white men have declined substantially between 2010 and 2018. That is the yellow line that you see. And the purple line between 2010 and 2018 has remained unchanged. We also know that if we look at regions, that Blacks in the South had the highest number of HIV diagnoses compared to other regions. And so first of all, in every region, the Northeast, the Midwest, the South, and the West, Blacks make up the greatest proportion of people who are diagnosed with HIV, even though they represent a very small percentage of the population in those areas. But the South, Black people in the South, make up the greatest proportion of those HIV cases in that region, 52%, as compared to 30% in the West, 40% in the Northeast, and 47% in the Midwest. But when you look at just the sheer numbers in the South, it is extraordinarily high compared to the rest of the country. This is at least twice as high as the nearest number. So we have a problem of HIV disparities, particularly regionally in the South, among the population of Black people in the South, and particularly among men who have sex with men in those communities. So there are strategies that have been designed and deployed that I think account for a great deal of why we saw that decline in new HIV infections among white men. One of those is pre-exposure prophylaxis. So pre-exposure prophylaxis is a strategy that principally involves the use of antiretroviral medication, which are medications that are typically used to treat HIV, but taken at a dosage level that is not sufficient for HIV, but a dose that will be sufficient to prevent HIV infection if a person becomes exposed. And so that strategy has been around for quite some time now, and has been not the main driver, but a big contributor to the declines in HIV in other populations. But it has not had the same impact on Black MSM, even though this technology has been around now for quite some time. So in 2014, there was a study that's conducted by Lisa Eaton that showed a low awareness of PrEP among Black MSM. That at the start of when this technology or this drug was approved by the FDA, many Black heterosexual men did not know about it. And that I think when they first did the study in 2014, perhaps, I think it was 2010, it was about 20%. And then 2 years after the drug was approved, it had increased to only 23.5%. And even that increase was not statistically significant. So we can't even be sure that it changed at all. So that Black MSM in general, at least at this time period, didn't even have a serious awareness or broad awareness of the availability of this particular prevention tool. And there are some reasons for that. Some work that was even done out of Yale, I think Sarah Calabrese, who was at the time a fellow in Sierra at the Yale School of Public Health, had done some work to find that providers approach the topic of PrEP differently when they're talking to Black people or Black gay people. For example, in the studies that she led, they found that providers were less likely to want to offer PrEP to Black people compared to white people because they saw offering PrEP as a way that sort of sanctioned what they thought of as irresponsible behavior. And so it wasn't clinical decision-making that was driving what they decided to offer, but it was sort of a social evaluation of what they thought the patient should or should not be doing, or whether or not offering this was some permission for them to continue a behavior that the provider evaluated as sort of morally problematic, right? So imagine if providers think that more broadly, that it may not be so unheard of that many Black folks may not even know about PrEP because providers are less likely to bring it up to them. Another finding from Calabrese's study was that clinicians also made decisions about whether or not they thought the patient had the capacity to do what it took to adhere to PrEP, to access it and to adhere to it. And that generally providers evaluated their Black patients as being less likely to be able to access it, whether they could or not, but they thought they'd be less likely to access it and didn't think they really had the capacity to do whatever it would take to maintain adherence to the medication, which is important because in order for PrEP to have a prevention impact, clients, patients must adhere in general to a daily oral regimen. So I'm saying this because even though what this first study talked about, that there was a low awareness of PrEP, sometimes our thoughts about why Black MSM have low awareness of it is about their literacy or whether they're accessing information. There's another part to this, which is structural, which is whether or not there are structural impediments to them being able to be presented with the information. And some of that happens through the healthcare system. And healthcare providers are implicated in that as well. So in 2017, another study that was published by Canny showed that there was high PrEP awareness. So a few years later, after the Eaton study, that there was higher PrEP awareness, but lower percentage of Black MSM had discussed PrEP with their provider, and then they had lower odds of PrEP use. So even after we got through the hurdle of understanding what PrEP is and how it works and how it might benefit people's prevention goals, there was still low usage and there was still low percentage of Black MSM who had this discussed with them. As a matter of fact, there's been research that actually shows that healthcare providers are less likely to talk to Black men about same gender sexual behaviors or same-sex behaviors or homosexual behaviors or whatever you want to call it, that those discussions are less likely to be had when a provider is talking to a Black man or a brown man as compared to conversations that they may find more easy to have or questions more easily to ask if the patient is a white man. So what I'm going to show you now is, we know that the issues that are driving these inequities are not just issues about whether or not people personally understand or aware of PrEP or want to decide to take it or not, but there are also social and structural factors that have influence on HIV infection and factors that influence it. And so what I'm showing you now is data from a study that I published this in the Journal of Urban Health, and it is a study from HIV Prevention Trials Network 061. That's how they named their studies, by numbers. So this is 061. And this was a study that was done in 6 cities in the US. I have to remember them. It was Atlanta, Boston, Los Angeles, San Francisco, New York City, and Washington, DC, right? And I think the data that I'm showing you here will just be from New York City, but across the top, you'll see what we selected as variables that indicated various types of hardship, categorized into 3 domains: economic hardships, social hardships, and legal hardships. And then across the this axis, the vertical axis, you'll see risk-related behaviors that are associated with HIV infection and also associated with having a sexually transmitted infection. So we wanted to understand whether or not these social structural factors were influencing HIV risk-related behaviors and STI incidents. And so first we looked at prevalence of economic factors. So what you may immediately notice is that among people, for example, if you look at the first row, who reported having condomless insertive anal intercourse, that is what CIAI stands for, that a very high percentage of them were unemployed, 76%, had a recent job loss or financial crisis. So that's what the other rows represent as well. So there are a high proportion of these individuals who had economic hardships. And we also found that recent job loss was associated with condomless insertive anal intercourse. And having a recent financial crisis was associated with having greater than 2 male sexual partners among this sample. This is a sample of Black men who have sex with men. Was 1,500 people in this sample. So these economic hardships, for example, these particular variables were associated with condomless insertive anal intercourse, which is an influencing factor for HIV infection and STIs, and having greater than 2 male sex partners in the past 6 months. So let's move over to look at legal hardships. So the first thing that should strike you is that if you look at history of incarceration and recent arrests, the sheer percentage is startling. It should be startling. Maybe not surprising at this point, but I still find myself startled every time I see it. But among folks who reported condomless insertive anal intercourse, condomless receptive anal intercourse, and greater than 2 male sexual partners, is stunning the high percentage of the high proportions who had a history of incarceration and recent arrests. The study was not targeted to people with recent arrests or incarceration history. It was not a random sample, but among the sample that was taken for the study, it was a high percentage of folks who had incarceration history and recent arrests. And I guess I will say at this time, because this is a New York City slide that I'm showing you now, this was during the time of stop and frisk. I don't know if that was a technical name for it, official name, but that's the popular name for it, stop and frisk in New York City. And so here is part of the impact of that you could take a sample of men from New York City, 300 people, and 82% in this time frame would have reported having been recently arrested. So one implication of these legal hardships that we found is that having a recent conviction was associated with having an STI at 6 months from when they entered the study. This is important because having an STI increases someone's chances of acquiring HIV if they're exposed to the virus tenfold. And then social hardships. So we looked at two. One was unstable housing, not necessarily homelessness, but not having sort of stable permanent residence and not having health insurance. And what we found among those two was that if you reported unstable housing, that was associated with having an STI at 12 months, almost twice as likely to compared to people who had stable housing. So again, having an STI is a significant influencing factor, increases someone's risk of HIV infection upon exposure at least 10 times. So what I've described to you is sort of this complex mix of factors that we don't often think about. Maybe I shouldn't say we don't often think about it. That's not often thought about when we think about care. What does care mean? And many times our conception of care is what happens in that clinical interaction. But what we know is that the things that happen in that clinical environment are not the only things that determine whether or not a patient is going to have a higher risk for having a poor health outcome. In this case, we're talking about HIV infection. There are other things in the constellation of the person's environment that have a significant impact on it. And if we want to decrease inequities in HIV infection, then we have to pay attention to those things. One of the things that we hear in research is that some of the problems are too big. And indeed, these are very big, complex problems. And the traditional approach to, saying the problem is too big, so we should tackle a piece of it, I'm not convinced that's ever going to make that line where Black MSM, the HIV incidence among that group has not changed. I think tinkering around with what we think is feasible, it just will not do it. If the problem is complex, I think we need intervention strategies that can match that complexity. And so the nation's strategy, the current strategy of the United States for reducing HIV infection is really to increase HIV testing. And this is what you see on the left-hand side of your screen, to increase HIV testing so that we can better identify people who are living with HIV and differentiating those from people who are not. And then among people who are not living with HIV, to increase the proportion of those people who are on PrEP. Whether or not it's the oral form, which is current, or this new injectable long-acting form, which is likely to be approved by the FDA very soon. And then among those who are determined to be living with HIV, to increase the proportion of those people who are in treatment on antiretroviral therapy and are virally suppressed. We know from an abundance of science that when people are virally suppressed, that they are not able to transmit the virus on to others. So this is the nation's strategy. And it makes sense scientifically. It makes sense clinically. The challenge is these strategies that work scientifically don't often have an equitable impact. That the thing that I just described, these social determinants, act as a wall, a barrier to these interventions, these clinical tools having an equitable impact on Black people in general, and in the case of HIV, Black MSM in particular. And so what I propose with some colleagues of mine, Chris Byrer, who is an epidemiologist at Johns Hopkins University, and Bob Bremian, who is a clinical psychologist at Columbia University, is to develop an integrated strategy that would address the issue of how do we get efficacious biomedical interventions to have an impact on Black MSM. And we know that in order to do that, we have to address the social determinants of health and have serious strategy that can match the complexity of the problems that are keeping these interventions from having the impact that it should be having. And so that's what I'll describe to you now. The study that we'll be leading, this is currently in development, late stage development, but development, is an HPTN study, and it's number 096. And the overall purpose of the study is to reduce HIV incidence among Black MSM, particularly in the South, because as I showed earlier, that is where the majority of HIV incidence is happening in the United States in general. And in that region, Black MSM are disproportionately impacted by HIV infection. And so we want to assess an integrated HIV status neutral, population-based approach. Status neutral meaning is not just focused on prevention or treatment, that it focuses on prevention and treatment. And population-based in that this is not a traditional approach where we identify cohorts of people and intervene with those cohorts or that sample and follow them over time. The interventions that I will describe to you are designed to be applied at community level. So to assess an integrated HIV status neutral population-based approach that is designed to reduce HIV incidence among Black MSM in the South by increasing HIV testing, increasing the uptake of pre-exposure prophylaxis, adherence to pre-exposure prophylaxis, and also increasing rates of viral suppression. This study is sponsored by the National Institutes of Health. Principally, it is the National Institute of Allergy and Infectious Diseases, but also with some support from the National Institute of Mental Health. And we're hoping the National Institute of Nursing Research, but to date, they have not signed on as an official sponsor for this study. Our other federal partners are the Centers for Disease Control and the Health Resources and Services Administration, or HRSA. So what we want to find in this study is that the integrated strategy that I'll describe, we want to increase the prevalence of PrEP use, which we will assess using biological samples, principally dry blood spot assessment of to detect whether or not the drug metabolite is in people's blood at baseline and at the end of the study. And also we want to see whether or not we can decrease or increase rates of viral suppression in these communities, and we will do that based on surveillance data that the CDC has agreed to provide to the study team. So we're going to use 4 interventions. The first one is focused on health equity, and this is, I shouldn't rank them, but this is a very important component because what we know is that the issues that impede Black mental health sex men from being able to access testing or PrEP or treatment are issues that are not just centered in the HIV sector or centered in the healthcare sector, that it really does require a cross-sectoral approach to help address some of the issues that are getting in the way, to help tear down that wall that you saw on the previous slide. And so for our health equity intervention, we're using a model that has been developed and implemented nationally, really, not in every community, but many communities across the country, by the Black AIDS Institute. That institute is based in Los Angeles, and they have a program called the Black Treatment Advocates Network. And it is a leadership program, a coalition, community coalition model that we want to harness, because what it does is it gets stakeholders, including providers, community leaders, working together towards a goal. So this could be people in the transportation sector, education, employment, criminal justice, but also healthcare, to say, listen, we have a goal here. We're trying to reduce new infections among Black gay men. What are here's some of the things that we know get in the way. How can we organize our services or cooperate better or differently in order to make sure that when Black gay men come to any one of our services and they have a particular profile that might indicate they could be at risk for HIV or otherwise benefit from testing or PrEP or treatment, how do we make sure we make this as easy as possible for them to get access to these things and reach either prevention or treatment goals? So we'll use that health equity component because we know that in order for us to achieve these outcomes, there has to be a larger community effort that is coordinated, that is focused on how do we make sure we can achieve these outcomes. And that is at the community level. The other intervention strategy at the community level is using social media influencers. This is key the social media influencers will happen at two levels. One is sort of national level influencers, and you can sort of imagine who some of those people might be. But the goal of the national level influence is to raise larger awareness around the availability and the appropriateness of testing, of PrEP, and of treatment, to help send messages that reduce stigma that Black MSM face, how people understand and see them, which might affect how they're treated in general, whether or not they feel like it's safe to go walk through a neighborhood down the street to get to a clinic. It may also influence how providers or other healthcare workers or other workers in the healthcare setting see them as well. So the social media influence is designed to grab people's attention, right? These are folks who folks in these communities listen to in general to help transform some of these norms that are stigmatizing, that get in the way of Black MSM being able to get appropriate, high quality care. But national influencers don't often, may not ever know what's actually happening in local communities. And so we also need to partner with local social influencers. So we'll do that. So the national influencers will direct people or link people through some mechanism. I haven't figured out what that actually is going to look like yet, to local influencers who will have more credibility of saying, this clinic is a clinic where you can go to, or this is the place where we know there are services that are friendly and appropriate and respectful for Black men who have sex with men, for example. And so this dual strategy, social media influencers on the larger level to help transform norms that can be anti-stigmatizing, and also linking to local social media influencers that can help steer people towards some of these interventions locally, because people recognize their names and faces as people who actually know what it's like to live in those particular communities. The third one, and this is at the organizational level, is intersectional stigma reduction. And as I described to you earlier when I talked about the work that Sarah Calabresi's done and Cannon published, is that a lot of what happens, a lot of what impedes the ability to access these efficacious interventions happens at the healthcare facility level, and that the target of the intervention may not actually need to be necessarily the Black men themselves. As I mentioned earlier, awareness is high. People know what it is. Willingness is high. People are willing to get access to these things, but something else is still getting in the way. And so what we've done is focus our attention on targeting the healthcare facility itself as in need of intervention. And we're calling this intersectional stigma reduction because we think there are a couple of things that are at play here. We noticed from the research literature and from some of our own work. It's the intersection of anti-Black racism and how it manifests within these clinical environments. So not just in interpersonal interactions, which can happen too, but even in how clinic services are structured, how forms might be created, the question that they ask, that those structurally can be impediments to people getting access to care, or they can also communicate a particular preference about what people can and can't say, what they may or may not be able to disclose, not just about race, because you can identify somebody. I mean, race is this social category that's based on skin color, so it's not like you can hide it typically, but the race part interacts also with the sexuality. And so in addition to anti-Black racism, it's designed to address how it intersects with sexual stigma, principally homophobia, and gender nonconforming stigma. So these are the three things that we're very interested in addition to HIV stigma among people who are living with HIV, that when a Black person, a Black gay man comes into a clinic, they're not experiencing stigma because they're Black or because they're gay or because they have HIV or because they don't conform to traditional norms of masculinity, but it's all four of those at the same time. How people see, how systems or healthcare facilities respond to, let's say, a gay man will vary based on the race of the gay man, because the systems and people also respond to that intersection. And so we're very particular in this study that we're interested in reducing stigma that happens at the intersection of Blackness, gayness or queerness, gender expression, and health status, particularly HIV. This is a healthcare facility based intervention where we plan to train. So it's a whole facility approach. And so we're aiming to train 75% of the relevant staff in the facility. And when I say relevant staff, it means we think about what is the care pathway? Who are all the people or types of people or job categories that these men are likely to encounter as they go through care at a facility? We want to make sure all these people get exposed to this particular intervention. So one is the foundational training that will be led, that really gets into the issues of how intersectional stigma looks, how it manifests in their practice, and how their practice can be transformed to address it. And then it also includes strategies. So it's not just saying, here's how this healthcare environment works in ways that disadvantage Black gay men, but what can we do about it? And it involves a quality improvement collaborative approach where these healthcare facilities that pick a similar goal will work together to figure out how do we improve our services together, sharing best practices and knowledge to make sure we can help achieve this goal, which is how do we increase testing among Black MSM? How do we make sure that we have an environment such that when we ask the right questions of Black men, that they feel safe that they can disclose information without being judged or harmed or disadvantaged in some way. And then how do we also support those if we can increase our rates of testing to be on PrEP if that's what they want, or if they have HIV to be linked to engage in treatment and achieve viral suppression. And then the last component of this is peer support component. And it's actually the only component that is happening at the individual level or interpersonal level. This is online web-based peer support that all the Black gay men in our intervention communities will be able to receive. This is online and it's virtual. Well, maybe it's not virtual. It's real peer support, but it's online peer support. That they can access this regardless of what facility they go to, so that there is some continuity built into the peer support that they receive. So again, this is designed to help people understand that there's folks they can connect to without having to disclose their identities. If you remember, I said this is intervention in the South. The South is a very particular cultural space. And so there are a lot of barriers to people being able to talk openly about who they are in order to get support. And so we wanted to remove that you don't have to go to a particular place, a brick and mortar facility to get that support, because there are many reasons people don't go, that you don't have to attend a group session, which sort of forces you to disclose your identity to people in the group who you might not even know in order to access support. So this is about finding other ways to give Black gay men in these communities access to peer support that can help them process and think through things about what might be barriers to testing, or decisions needs around clarifying whether or not I want to start PrEP or not start PrEP, or if they're not engaged in HIV treatment services, but they're living with HIV, support around how do I process that in ways that can still help folks achieve their health goal. So these four strategies, these four interventions are part of one integrated strategy. The health equity component, the intersectional stigma reduction, which are both, the health equity component, the intersectional stigma reduction, the virtual peer support, and social media influencers are all designed to have an impact across this continuum. So again, if you look down the middle, we want to increase HIV and STI testing. And among those who are determined to be negative, to increase the uptake and adherence to PrEP. And that then increases the percentage of Black MSM who are protected from HIV, because PrEP will offer them a level of protection. And then among those who have HIV, to increase the proportion of those Black men who are on ART and adherent to ART, and then increase the percentage of those who are virally suppressed. And as I mentioned before, when people are virally suppressed, they are not able to transmit the virus onto others. And that these things together will lead to reductions in HIV incidence. We were really thoughtful about how would we do this and where would we do it? So the first thing was at the time we were thinking of this, the US had launched the End the HIV Epidemic Initiative. And what it really said principally was that most of the HIV infection in the United States are accounted for in a small number of communities. And what you see on the map are the communities in the United States that account for the majority of HIV infections. So what we decided was what we will do is have a community randomized trial, which is that we will select communities from the list of ending the HIV epidemic jurisdictions, because we know those communities have been identified and prioritized by the federal government as the places that have the greatest need. That we would select communities that were in the South, because we know the epidemiology showed us that that is where the greatest percentage of rates of new infection were happening. So we would randomize communities to receive the intervention or receive standard of care. So again, this is very important. This is a population-based intervention, so it's not enrolling individuals and randomizing individuals to conditions. What we're actually doing in this strategy is enrolling communities, or how should I say that? Communities are, or I guess you can't really say communities. The consent to participate is really happening at the jurisdiction level, and that those jurisdictions, there'll be 16 of them who participate will be randomized to either receive the intervention package or standard of care. What you see here are the proposed pairings of the intervention of the study communities. And so these are the ones that have, I think actually all of these have agreed to participate except Tampa, St. Petersburg, that region, and Little Rock, Arkansas. So except for those two, all the other communities have agreed to participate in the study. So there are 18 on this list. We only need 16. So we will at some point get down to a list of 16, and that will represent roughly about 84,000 Black MSM, who we expect will be, maybe I shouldn't say 84,000. So 84,000 is the 16 communities. So half of those, which will be randomized to the intervention, so about 42,000 Black MSM will be actually exposed to this intervention through this particular strategy. So we paired the communities. So that's what the colors represent. So you see Birmingham, Alabama is paired with Columbia, South Carolina. Those are the pink. If we look at the orange at the very bottom of the screen, that's Montgomery, Alabama, that's paired with Greenville, South Carolina. So we went through a very exhaustive process to identify why we would pair these communities. It was based on size, population size, excuse me, and some degree to some cultural aspects, the percentage of Blacks in those communities, the HIV prevalence among Black men in those communities, and also PrEP use among Black MSM in those communities. We actually don't have data on PrEP use among Black MSM in particular. We do have data on PrEP use that we use for Black men, but what we do know is that the majority, maybe 95% of men who use PrEP are gay men. That is not a strategy that is widely used among heterosexual identified men or men who don't have sex with men at all. So we're pretty confident in these matches. And so what we've done is we paired them. So we were randomized in those pairs. So in the Birmingham and Columbia example, one of those communities will become the intervention community, and one will be the control. And the same thing for the other pairs. To accomplish a study of this feat requires a lot of partnership. And I will say that, my goodness, maybe for the last 2 years, even in COVID, we've been really working hard with partners to make sure that what we're proposing is relevant, that what we propose is acceptable, that people say this is something we want to do here. That includes a lot of work with our federal partners that you see across the top. Principally, I think the main partner really has been CDC and really helping us understand where these inequities are, a commitment to say, if this worked, could we scale this up? And so that was a very important sustainability question about not just determining whether or not we can show evidence that this strategy would work, but if we did, is this something that the federal government would make a priority and scale up? So we did get that confirmation. HRSA was important because a lot of what I talked about in terms of intersectional stigma happens in healthcare facilities, including federally qualified health centers. And so having HRSA on board to say, hey, we want to do this in a lot of facilities, in at least 8 cities, and many of these are facilities that you fund, having their support and endorsement to do that, and also a commitment to saying, if this works, it is something that we could work into our funding contracts that we have with facilities about implementing this as part of their grant. And then very important institution like the Black AIDS Institute, when I talked earlier about getting consent from jurisdictions, it really was these ending the epidemic councils that each jurisdiction was responsible to set up based on guidance from the federal government via the CDC. And these typically included groups that were led by the public health departments in cities, but also included local community-based organizations, clinics, and universities. And so we were able to go to groups that had already come together, that had already been identified as sort of the lead coordinator group for those communities who were trying to do this work. So we proposed to them that everybody's already trying to do testing and PrEP uptake and treatment. But if we continue the same pattern that we have in the past, that you may see some reductions overall, perhaps overall, but you may not see reductions in Black MSM, that the disparities will continue and maybe even widen. And so when we proposed our strategy was a way to supplement their ongoing work. So we want to randomize you to either intervention or control to see whether or not, if you do these additional things, can you really have serious impact on the epidemic among Black MSM? Can you reduce those inequities? And then also a community strategies advisory group, which included stakeholder groups that represented Black gay men and nurses, including the National Black Gay Men's Advocacy Coalition, the Black Gay Research Group, the Association of Nurses in AIDS Care, and the National Black Nurses Association. And then lastly, we worked with Gilead Sciences, and that was important. I'll talk to that as well, because what you'll see is that Gilead and ViiV are going to be important partners in another area of equity that is important to the study. And that is, for any community that participates, what we are working out with the drug manufacturers is that PrEP, right now, Gilead Pharmaceuticals is the manufacturer that produces the only 2 FDA approved forms of PrEP, which are Truvada and Descovy, to make that donation available in every city, regardless of whether or not this community is randomized to the intervention. So all the communities, all 16 communities will have access to these products, or Descovy in particular, at no cost. Gilead is also considering making a donation of Biktarvy, which is a once-a-day HIV treatment, antiretroviral treatment, available both at no cost in intervention and control communities. And that its availability is based on clinical indication. That is, the availability is not just for Black MSM, but anybody in the community, cisgender women, transgender women, white gay men, it doesn't matter. If they have a clinical indication for PrEP or for treatment in which that particular product may be useful, they can have access to it if they're in one of these communities. And we thought that was important because we were thinking about, how do we, as a research team, also incorporate equity into how we do it? That, I don't know if fair is the right word, but it certainly didn't seem right for us to say, well, if you happen to be randomized to this particular intervention, you'll get the this condition, you'll get the intervention strategy, but that the underlying sort of issue, which is about whether or not this medication is available at base, we don't address. And we want to take a different approach. And so we got through a lot of approval processes at a federal level, but that allowed this to be a part of what communities will receive if they participate in the study, regardless of where they're randomized to. Oh, I didn't also mention ViiV. And so ViiV Pharmaceutical is also the manufacturer of a long-acting injectable form of pre-exposure prophylaxis, and that is called cabotegravir. And so ViiV, we're also in discussion with ViiV about making cabotegravir available, again, to anybody who has a clinical indication for it across the intervention and the control communities. And so this is how we expect it to work. This is a depiction of the mechanisms of action. And so on the left, you see this integrated strategy, these 4 intervention components at the 3 levels, so health equity and social media influences at the community level, intersectional stigma reduction at the organizational level, and peer support at the interpersonal level. That these strategies are designed to all work together to do a few things that we identified earlier on were issues that prevented Black MSM from being able to access prevention tools and treatment tools. One is to increase multi-level social support at the community level. So even the environments where they live, we want those to be promotive and supportive of prevention and health activities. That it will also lead to reductions in multi-level intersectional stigma. So that is stigma both at the social level, but also the stigma that might be experienced will be present within healthcare facilities, which is very, very important. And then decreasing structural barriers to healthcare services. And as I mentioned, key to that is the health equity component, which is really based in the Black Treatment Advocates Network model, which is that sort of multi-sectoral cooperation model that's designed to get people to really work together to figure out how do we make it as easy as possible for Black MSM to get access to these services so that they can test as much as they need to, be on PrEP or be into treatment. And that if we can address these 3 things, the social support at multiple levels, intersectional stigma, and structural barriers to healthcare services, then we can increase individual level agency. And so agency is very important. As a matter of fact, there was a talk, maybe it was last week, from Steiner. He is the head of the United Nations Development Program. And in their Human Development Report, they talk about agency, which is more than whether or not people feel they can do it, whether they're motivated enough to do it, but actually is the system structured in a way that allows it or facilitates it. And so, how do I say this? If you think back to the slide I showed you earlier, it showed the Black MSM on one side of a wall and the biomedical tools on the other side. So, in one way, efficacy would be how motivated are the men for using those products to improve their health. Agency would be, is there a way to get them across that wall? Because the wall is real. And the presence of that wall has nothing to do with the fact of men's motivation to use those services, that those are structural issues. And so by addressing those structural barriers, not only can we, in the first 2 instances, increase people's willingness and motivation to do it, but create a system that actually makes it possible, right? That decreases the barriers that are there so that folks can actually enact on their motivations. And that if we can do that, we can increase HIV testing, and depending on the diagnosis, increase rates of virus suppression through ART, uptake and adherence, increase PrEP use, and that if we can do all those things together, we can decrease HIV incidence and Black MSM. Again, this is about how do we get that line to start trending downward. We saw from 2010 to 2018, there was really no change in new infections, even though there was a significant change among white gay men, that we really want to get that number to decline. And we think this will be a way to demonstrate that this is how you do it. And we can generate that evidence that policymakers can then use to develop and structure programs in their communities that can do this on a national level. And so in closing, this is the right population. If there was ever a healthcare issue and a population that experienced various types of marginalization, this is one. And this is something that we've known for a very, very long time. And I think even for a very long time, we've known what some of the issues were, but not really had an opportunity to do something as big as what we're proposing. Because what the problem is huge. And I think traditionally in the NIH sort of world, you don't get R1s to do this type of work. It's outside the scope of what you could expect to ever get funded to do. So we're trying to do something that's not been done before. The time to do it really is now, particularly because there's I think, more willingness to admit to the challenges of anti-Black racism and other marginalizations and the impact it has on health outcomes. I think COVID-19 has really allowed that to be seen very quickly. I mean, those of us, Dean Kirth can tell you, and others who have done work in HIV have known this for a very long time, but because of the way that sort of HIV has unfolded, is not be able to see it in such a stark, fast, real-time way that COVID-19 allowed us to see instantly and immediately. And so you can't hide from this anymore. So because there's much more focus now, more attention or recognition of the role of inequities in health outcomes, this is the time to do it. Multi-level, multidisciplinary, and multi-sectoral interventions are complex, no doubt about it. But so too are the problems that we're trying to address. And we can't try to seriously address complex problems with simple unidimensional interventions. We've been trying to do that for decades. It has not worked. Black MSM are getting infected more, they're dying more, and we have to stop, and there has to be a will to do research that can see whether or not there's evidence that these types of interventions get us closer to equity. And that robust study designs can be used to evaluate the impact of integrated strategies on the use of biomedical interventions. And so, again, we're not testing the efficacy of testing. We already know it works. There's plenty of evidence that says that these tests work to differentiate HIV infections. We know PrEP works. We know that treatment works. What we want to do is have a strategy that can optimize its implementation in these communities so that they have a better impact on Black mental health, sex with men. This focuses on making the tools that we have work better and more equitably. So I'm very proud to be a nurse involved in doing that work, and happy to present it here and look forward to your questions. Thank you.
Thank you, LaRon. Great presentation with, I think, very thought-provoking issues for all of us, whether we're system leaders, clinicians, or scientists. I have 4 questions here from the audience, or actually less than that. One of them entered a couple times. So let's start with the first one. Is there resistance in the Black community to embrace and support MSMs? Could this contribute to decreased use of treatment? And should we focus on developing support in the Black community for MSMs?
Yeah, that is an excellent question. I think that, especially across the South, I mean, many of these places that we're talking about are in Black communities. Some of the clinics that we're talking about are clinics that are predominantly Black. And so these ideas around racism and homophobia are not limited to any particular cultural group. They're here. So many of us, if not all of us, are subject to acting in ways that perpetuate these things, including Black communities and facilities in Black communities. And so part of why the health equity component is so important is because it is, well, 2 things. that it is a group that is about Black leadership and working together towards shared goals. And so what we have to do, we've not done it yet, but what we have to do in that model is say, we have a goal. Our sons, our brothers, our uncles, our dads are experiencing a disproportionate exposure and infection from this virus. We have to figure out how to stop this. We have to do it together. Regardless of what you think about a behavior or sexuality, we have a goal here, and we have to figure out how to do it. And the people involved in that are not just Black gay men. They are women, they are ministers who have particular sort of maybe theological ideas about it, but much of it is political. But to say, we have to find a way to do this. This is a community problem. And we think that that approach, helping communities, and with the smaller Black communities understand that this is a problem that we have to work together to help solve, because the public health system has not solved it, and it may not be inclined to solve it. And a lot of what may be happening, a lot of how we can address these social stigma can be the support that we can provide to Black women from within our community that could be a driver. I don't think it is the dominant driver, because most Black folks are not, or Black gay men are not getting service in the healthcare system that are run by Black people. Our system isn't designed that way nationally. But I do think that stigma in the community is also important. And what we want to do is also address that too, especially in parts of the South where, you know, in some spaces, right, you go to an LGBT clinic, it's okay to talk about being gay or bi or questioning or whatever it might be, although your Blackness might not get you as good a service as you want. The reverse is true. You might say, oh, here's this clinic, they focus on Black people, and so you're not worried so much about being subjected to types of racism, but the fact that you're gay might not allow you to get the best service that you need to get. And so there's work to do across it, which is why we're taking this intersectional approach, because regardless of where people may go, they may experience some types of oppression. It may be more salient depending on where it is, but it does not mean that Black communities don't have a stake in improving the ways in which they engage Black gay men.
And then just one more question. And this actually may relate to some of what you just said in your answer. European gay men from similar education and socioeconomic status have HIV, but at a lower rate. Do European American gay men do they not face a similar stigma as Black gay men?
Well, I think, well, I will have to assume that when the question says European, it means white, because there are a lot of Black and non-white European people too. So I think that, yes, I think they face challenges for sure. But I think there are other explanations that we're trying to test here. We do know that in general, white gay men, and I want to couch this in a sex positive way, right? And this is from somebody who worked in a sexual health clinic, right? And, you know, we know that white gay men have less proclivities around sex, right? Can be very free, not a whole lot of hangups. That Black gay men are a bit more sexually conservative. They don't have as much sex necessarily in general. And there's data from CDC to show this, or what we might consider high risk sex, but they get HIV more. How is that possible, right? Because I think a lot of people say, well, maybe the Black gay men are doing more things and that's why they're getting more. Well, actually what we're finding is that prevalence of HIV in sexual networks is the predominant driver of infections. So if you're a white gay man, to use the example, who has 100 sex partners and you live in, I don't know, some suburb, someplace where there's not a lot of HIV infection, your chances of getting HIV is low, even if you have 100 sex partners and really use a condom. But if you're a Black gay man who lives in a neighborhood where there's a lot of HIV infection, You don't need to have 100 sex partners to be exposed to HIV. You can have 2, right? The CDC said that the lifetime risk of HIV infection among Black gay men is 1 in 2, 50%, right? You don't need to have a lot of sex partners to get exposed to HIV if you're a Black person living in a poor community. A lot of reasons for that. If they're not testing, that means that they're not testing a lot. It means that the diagnoses aren't even discovered. When people get tested and they're diagnosed with HIV, they do things differently. But it means that you have to have access to services and get testing. But if that's not happening, there can be a lot of circulating HIV in the community that it doesn't take, it can be very easy to get exposed to HIV, even if you have very low risk behaviors. And so we think that is part of what is happening, is that the drivers are systemic drivers, are systematic drivers that show up in individuals. And I think how we interpret them is that, well, the people must be doing something different. But the data has shown us that that is not the case for a long time. We just have not had interventions designed to try to address that. But at least in the case of the disparity between Black and white men, we know that it is not a difference in the behavior that drives it, because the highest risk behavior is actually among, I hate to say highest risk, but if we looked at behavior as the dominant risk, then you would expect white men to have HIV more, but they do not. And that's the reasons for it.
Thank you. That, I think, concludes our Q&A period at this time. Thank you very much, LaRon. And I guess we go to a break at this point, right?
Yes, we are going to be taking about a 3-minute break. If you can please just make sure that your video and your mute is off. We will begin promptly at 10:10 a.m. and we ask that you do not log out of the meeting. Thank you.
Okay, welcome back, everyone. It is now my pleasure to introduce Dr. Abigail Wilpers, who completed her MSN and PhD degrees at YSN. And Dr. Wilpers is a women's health nurse and a postdoctoral research fellow in the National Clinical Scholars Program here at Yale. She practices and conducts research in the field of maternal fetal surgery. As a member of the Fetal Care Center team at Yale New Haven Hospital, Dr. Wilpers has cared for women and families whose pregnancies are complicated by fetal anomalies. She is active in national and international professional organizations, and she serves on the board of directors of Hope After Loss, a nonprofit organization that supports local families experiencing pregnancy or infant losses. Dr. Wilpers' presentation is entitled The Parental Journey of Fetal Care, a Systematic Review and Metasynthesis. Dr. Wilpers.
Thank you so much, Lois. Let me share my screen. Okay. So good morning, and thank you so much for the opportunity to present the parental journey of fetal care at YSN Scholars Day. The diagnosis of a fetal anomaly during pregnancy can be traumatic and life-changing for expectant parents. As one mother said, "I felt shattered, like someone had destroyed me." Going ahead a little quick. Many different specialties and subspecialties are involved in diagnosing fetal anomalies. From the diagnosis process to counseling the pregnant person and their family about the condition and their options, and sometimes treating the condition during pregnancy or immediately after birth. This has historically been approached from a fragmented care model. Expectant parents navigate a series of specialists in different settings, all while experiencing overwhelming stress and confusion. As one parent explained, "I saw the pediatric consultant just once, but that was after the baby was born. No doctor knew what the other had told me, and there was a real lack of communication." While qualitative research was uncovering parents' dissatisfaction with the traditional care model, rapid advances in diagnostic and treatment capabilities began requiring more multidisciplinary collaboration during prenatal care. And thus, the needs of parents and providers led to the development of an integrated care model, often referred to as a fetal care center. Fetal care centers provide fetal diagnosis and pregnancy management by multidisciplinary teams who deliver comprehensive, coordinated, family-centered perinatal care and offer evidence-based and experimental fetal and neonatal therapies. A specialized nurse guides the parents, literally and figuratively, throughout the pregnancy. Since their inception, fetal care centers have rapidly proliferated across the United States. In addition, the intrauterine surgical interventions provided at this site continue to advance. For example, the diagram above shows the illustration of a procedure to treat spina bifida during pregnancy, and the photo to the right shows the shared scars of a mother and her baby. So as fetal care centers multiply and the populations of parents experiencing these novel treatments grows, it's important to ask whether this new approach to care is meeting parents' needs. The growing body of qualitative literature exploring parents' experiences in fetal care centers has provided important insights. The objective of this study was to synthesize the qualitative literature on parents' experiences in fetal care centers to reflect events that happened across the continuum of care and to better understand parents' positive and negative experiences with care delivery in this relatively new setting. Since this metasynthesis investigation focused on multidisciplinary care, we established a multidisciplinary research team. Our team represented the fundamental collaboration between obstetric and pediatric providers and included nursing and methods experts in qualitative and systematic review techniques. Metasynthesis is a scientifically rigorous approach in which qualitative studies examining a similar phenomenon are analyzed and evaluated to develop new concepts and provide direction for clinical practice or policy development. We use the meta-study approach, which comprises 3 analytical phases in which the research methods, data and conclusions, or theories of primary research are compared and contrasted. We conducted a systematic review of the literature in May 2019 and updated that in June 2020 to identify key articles focused on parents' experiences of fetal care centers. We identified 6,142 articles through the initial search strategy, 241 of which underwent full text review, and 13 were included in the meta-synthesis. Here you can see a snapshot of Table 1, where we collected and analyzed primary study information, including the qualitative approach, sampling method and data collection strategies, data analysis techniques, and conclusions and theories. Direct quotes and author narratives from the primary studies were analyzed using the qualitative approach interpretive description, which allows for the integration of multiple sources of complex clinically relevant data. We had 2 outcomes of our analysis: the patient journey map, which was created to display events that happened across the continuum of care, and themes associated with a positive care experience. The 13 primary studies were conducted over the last 2 decades and 69% in the last 5 years. Research teams from the primary studies represented a wide variety of disciplines and at least 11 different multidisciplinary fetal care centers across North America and Europe. The primary studies included 217 participants, of which 71% were identified as expectant mothers. Most fetal anomalies were primarily cardiac, as you can see in the pie chart on the right. However, of concern, limited sociodemographic data was provided for most study samples. Race or ethnicity was reported in only 6 of the studies and was predominantly white. We created the patient journey map to help readers walk through the parent's shoes throughout the experience, including each period of care along the continuum, from the first detection of the fetal anomaly to the fetal care center visit, prenatal care, and inpatient care during and after birth. The map also identifies aspects of healthcare delivery that served as barriers or facilitators to a positive care experience at each point of care. And finally, quotes from parents and authors of the primary studies exemplifying each stage of their journey. I'll use this map to guide us through the 3 themes associated with a positive care experience. As we walk through the map, I'll highlight a few key barriers and facilitators and integrate additional quotes to elaborate their meaning. We identified 3 themes associated with a positive care experience: gaining understanding and feeling understood, realizing agency and control, and finding hope and meaning. For this presentation, I'll illustrate these themes at care, but it's important to note that each theme was in fact present across the entire care journey. Gaining understanding of the baby's condition and prognosis was the parent's primary goal after fetal anomaly detection. Expectant parents described frantically seeking to understand the baby's condition, the possible cause, especially whether there was something that they had done or not done that could have produced the anomaly, what their options were, what their baby's life would be like if there was a chance of survival, and what the next steps would be. Throughout their care, parents also wanted to feel understood. They wanted to feel understood as people who have been through a journey. In other words, they wanted healthcare professionals to know their story, and they wanted to feel understood as parents trying to make compassionate decisions for their child. Although gaining understanding and feeling understood were important to parents throughout their care, for this presentation, I'll highlight critical examples of barriers and facilitators at the beginning of the fetal care journey. At detection of the anomaly, limited and confusing information from referring providers presented barriers to gaining understanding, which then contributed to anxiety, uncertainty, and a lack of trust in healthcare professionals. As one mother stated, "Something abnormal in the original ultrasound was why my doctor wanted me to go to the fetal care center. I had no idea what was going on." This quote and this barrier to gaining understanding embody the parental experience at this point of care. In contrast to the experiences at the referring practice, parents described more healthcare facilitators to gaining understanding and feeling understood once they reached the fetal care center. I'll highlight a few facilitators that provide particularly rich information for this theme. For example, parents appreciated being told early in the visit that the anomaly was not their fault and that how they were feeling and thinking was normal. As one mother stated, "The most important thing I learned was that I wasn't doing something wrong. These things happen." This removal of guilt allowed parents the space to take in and process more information and to feel understood and not misjudged as bad parents. Parents felt understood and were able to gain understanding best when healthcare professionals knew their story, respected their informational preferences, and acknowledged and validated their needs, feelings, beliefs, and decisions. For example, this figure shows two cases where the diagnosis and options were the same, but the contexts were drastically different. The woman in the first story felt that she was meant to care for a medically complex child and needed targeted information and support for her decision. The couple in the second story needed a lot of broad information and to feel that they would be supported and cared for no matter what decision they made about their pregnancy. If healthcare professionals did not take these kinds of differences into consideration, they would deliver information and ask questions in a standardized way that parents perceived as cold and some described as a barrier to understanding and decision-making. Our second theme, related to a positive care experience, was realizing agency and control. Parents described feeling helpless and powerless amidst the uncertainty and waiting inherent in the parental journey of fetal care. Some described this as the, quote, worst and hardest part of this entire experience. Feeling powerless as the parent of a vulnerable unborn or newborn child engendered a sense that they were not able to do their jobs. Most parents described needing help from healthcare professionals to feel like good parents who could make good decisions for their child and to feel that they had the power over the things that they could control. For example, at the initial fetal care center visit, some expectant mothers and fathers felt that their first act as a parent was deciding whether or not to continue their pregnancy. Some believed that continuing the pregnancy was giving their child a chance, while others believed that ending the pregnancy was protecting their child from unnecessary suffering. They felt like good parents when healthcare professionals guided them through the decision-making process and validated their choice. However, healthcare professionals struggled to respond to questions like, "What would you do?" or "What should I do?" When healthcare professionals avoided answering questions like these, some parents felt disempowered and experienced self-doubt, distrust, and arrested decision-making. As one parent described, saying to her healthcare provider, "I know we're not you, and I know you can't tell us what to do, but if it was your daughter, I tried. I asked about 20 different ways with different wording, trying to get the doctor to say something." During prenatal care, expectant mothers desperately wanted to know what they could do to exercise some control over their situation. As one mother explained, "I know that there's not much that I can be doing to fix anything, but what can I be doing to give her the best chances to be growing in the right way? That became my mission." Healthcare professionals helped parents realize agency and gain control by communicating with them regularly, helping them manage life logistics, such as a fetal care center social worker, assisting parents in navigating the financial challenges of fetal intervention, and by preparing them for each new phase of care with services such as specialized childbirth education classes and NICU tours. Being supported by healthcare professionals in parenting activities was a strong facilitator for realizing agency and control in the postpartum and neonatal period as well. Perhaps the most important act of parenting during this time was continuing to make decisions about their child's healthcare. As one mother described, advocating for a change in her child's pain medication schedule, I was worried, but I got them under control about that because they were giving it to him as they were reducing his gastroschisis. But Mama Bear kicked in, and so now they're giving it to him before so that it has time to get into his system. Our final theme related to a positive care experience was finding hope and meaning. In all 13 studies and throughout the entire journey of care, parents talked about the importance of hope. Hope was not necessarily the same as optimism or the expectation of a healthy baby. Although some parents did hope for a treatment to save their child or improve their prognosis, others hoped to stay pregnant until at least 28 weeks or to give birth to a live child. Even if their unborn child had a life-limiting diagnosis or they suffered a perinatal loss, many parents described having hope as essential to surviving their experience. For many parents, finding hope was a spiritual process that evolved along the care journey. The belief that they were, quote, supposed to go through this experience brought peace and acceptance to some. Discussing and documenting hopes as goals of care in the electronic medical record were important facilitators for parents finding hope and meaning throughout their care journey. Hope amidst uncertainty or poor prognosis did not mean that the parents were unaware of or in denial about reality, although this was a common misunderstanding. For example, one expectant mother with a life-limiting fetal diagnosis responded excitedly to seeing her baby's heart beating on an ultrasound because she hoped her baby would live at least until birth so that her heart could be donated. This hope helped give her experience and her baby's short life additional meaning. Hopeful reactions in the setting of a life-limiting diagnosis were sometimes misunderstood when healthcare professionals were unaware of the unique hopes held by parents and assumed they needed to be reminded of the poor prognosis. This was particularly likely if the parents saw different obstetric providers at each follow-up visit. Finally, many parents described how interactions with other families like theirs through support groups or through NICU connections helped them to find meaning and to see beyond the medical aspects of their experience and form a new family identity that reframed the diagnosis as part of their unique story. Parents also found meaning by focusing on how they could help other families going through a similar experience. As a parent from one of the primary studies explained, we feel privileged to be part of a study like this. Being able to be part of something that will help somebody down the road makes us feel really good. To help healthcare professionals to know how your patients feel about the care that they get and the information that you're giving them is really, really helpful. I want to highlight two important and related limitations that were alluded to earlier in this presentation. First, detailed and uniform participant characteristics were absent in several of the reviewed studies, limiting transferability of the findings. And for those studies that did report race and ethnicity, there was a lack of representation of people of color. This also limits transferability of the findings and signifies a major gap in our understanding of all people's experiences with fetal care. Based on our findings, I'll highlight a few specific ways in which the parental journey of fetal care could be improved at the healthcare professional and institutional levels. To enhance the parental journey from its start, we recommend fetal care centers foster their relationships with referring obstetric and midwifery practices. The time between detection and a first fetal care center visit may be improved through early connection with a nurse care coordinator. As a clinical expert, the nurse can use this time to educate and prepare parents while learning about parents' experiences, values, beliefs, and informational preferences, and then they can debrief the multidisciplinary team before the first consult so that the team has a chance to get to know the family before they arrive. One fundamental way to optimize parents' experiences when they're at the fetal care center is by healthcare professionals and institutions examining and enhancing their communication practices. Good quality communication underlined most of the facilitators in this study, and poor communication contributed to most of the barriers. Fetal care centers can seek out targeted communication training, such as Resolve Through Sharing's gold standard training in communicating with parents about perinatal death. This figure from our manuscript also provides evidence-based examples of scripting for challenging communication, including the fetal care center nurse's first call with expectant parents, examples of the reports that the nurse can provide to the multidisciplinary team to help them get to know the family prior to the visit, and finally, examples of ways to answer the question, what would you do? Future research should integrate both qualitative and quantitative methods and include detailed descriptions of health services, along with comprehensive and uniform participant characteristic reporting. We must prioritize forming diverse research teams to assess the journeys of people of color who have not been well represented in our research thus far. It's also important to investigate whether this lack of representation in research is actually a symptom of barriers that pregnant people of color face to accessing this care in the first place. These are both issues I'm focused on in my current doctoral fellowship at the National Clinician Scholars Program. Understanding the commonalities of the parental experience of fetal care creates a foundation for improving care and better meeting the needs of parents undergoing a painful and life-defining event. Although healthcare outcomes are not always positive, a positive experience of care is possible and can assist parents to cope with their grief, manage their expectations, and engage in their care. The findings of this study illustrate the ways in which healthcare delivery can facilitate or obstruct a positive care experience. So I want to say a huge thank you to my mentors from the Maternal Fetal Health postdoctoral program and to the leaders of the Fetal Care Center here at Yale New Haven Hospital who contributed to and supported this research. And now I would love to hear what questions and feedback you have. Thank you.
Okay, very nice, thank you. We do have a question here. Are fetal care centers widely available across the United States? And a comment that it was a wonderful presentation.
Oh, thank you. That is such a great and timely question. So fetal care center, the very first care center was founded in the 80s at UCSF. And by the turn of the century, there's probably 10 across the country, including one at Children's Hospital of Philadelphia, and basically urban centers on either sides of the country. And now in 2020, there are about 45 centers across the country, all with different scopes of practice in terms of the diagnoses and conditions that they treat, especially during pregnancy. So it is a rapidly evolving care model. And at this point, there's certainly more access to these procedures than ever before. So it's a really important time to be thinking about how this care is being delivered, because it is setting the standard for what I think is going to become a much more common method of maternal child care in the future.
Okay, and we have another question. What interventions are you hoping to engage in yourself as a nurse scientist that could be helpful and implementable nationally as much as possible?
So I assume that this is in terms of help interventions to assist improving the parental experience. So what we are working on at the moment is taking this information and expert and clinical participants, as well as parents who, some of whom have gone on to found nonprofit organizations like the Fetal Health Foundation. And we're working together to establish a parental satisfaction and quality indicator instrument that could be used at fetal care centers across the country. This would be something similar to the perinatal palliative care satisfaction and quality indicators instrument, which has served as a wonderful pilot for the types of populations that we would be assessing the satisfaction and quality of care for. So that is the first intervention that we're focused on, is being able to better measure and standardize the measurements of the patient experience.
And a third question that is a follow-up on this, what do you see as the greatest barrier or barriers in implementing your recommendations?
Thank you for asking that question. It's good to think about that all the time, right? So at the moment, and just what we've experienced with previous research, is the fact that the models of care are so different that it's challenging to find standards that we can all agree on. So for example, there is no formal definition of a fetal care center that is regulated. Texas was the first state to create regulation around fetal care centers, but it's not being enforced. So there is some movement to create voluntary national certification and to establish standards that fetal care centers must meet in order to call themselves by that name. But I think that the major challenges for that kind of work, as well as trying to assess the patient experience, is going to be these different, very different models of care across the country, and trying to find commonalities so that we can be measuring something in a meaningful way.
Okay, thank you for an excellent presentation. And that concludes our Q&A for this presentation.
Thank you so much.
Great. It's my pleasure now to provide an introduction for Yuri Wang, who is a third-year PhD student at the Yale School of Nursing. Yuri was an oncology nurse in South Korea before coming to the United States, where she attended Johns Hopkins School of Nursing and received a master's degree prepared as a family nurse practitioner. Her faculty mentors include myself and doctors Nancy Redeker, Samantha Conley, and Sanjong Yu. Her dissertation is about sleep health in young women with breast cancer, a very complex issue. And her presentation for today is Sleep in Young Women with Breast Cancer, a Narrative Review. Welcome.
Thank you, Dr. Knopf, for introducing me today. So hi, everyone. My name is Yuri Huang, and I'm a third-year PhD candidate at Yale School of Nursing. Today, I'll be presenting about my literature review on sleep in young women with breast cancer. Next slide, please. So a little bit about breast cancer survivorship in the US. In the United States, 1 in 8 women will have breast cancer in her lifetime. And in 2020, about 276,000 new cases of breast cancer were diagnosed. The 5-year survival rate of breast cancer is over 90%. As more and more breast cancer patients survive and thrive, there are about 3.8 million breast cancer survivors in the US, accounting for a quarter of total US cancer survivors. As you see in this histogram, non-Hispanic white women have the highest incidence rates of breast cancer, and non-Hispanic Black women have the highest mortality rates. Young women are a subgroup of breast cancer survivors. Next slide, please. Breast cancer is most prevalent in women older than 50 years old. However, there were around 58,000 estimated cases of newly diagnosed breast cancer in women under age of 50 years. And this number accounts for about 20% of total breast cancer cases. Next slide, please. Young women with breast cancer is a unique subgroup of breast cancer survivors. Clinically, these women often have delayed diagnosis of breast cancer, and aggressive subtypes of breast cancer are very common in this population. Young women also go through intensive care treatment, and they are likely to experience treatment-induced premature menopause. In terms of the life course, these women might have young kids at home, or might have just started a new career, or they might still go to school. They could be a caregiver of somebody else in the family. Given all these potential stressors from the life course and clinical trajectory of cancer treatment, young women often report uncertainty and fear of cancer recurrence. And these stressors can affect one's sleep. Next slide, please. Sleep is the human's fundamental need to perform day-to-day function, so it is a crucial part of our lives. Next slide, please. According to Bice's conceptual work on defining sleep health has 5 dimensions, including satisfaction, sleep duration, sleep efficiency, timing, and daytime alertness. When these dimensions are not optimal, people can experience sleep disturbance. Next slide, please. Sleep disturbance is one of the top 5 distressing symptoms, affecting up to 65% of breast cancer survivors. It persists even after cancer treatment is completed, affecting quality of life during cancer survivorship. Sleep disturbance is related to other symptoms as well, including fatigue, depressive symptoms, and many others. Next slide, please. Breast cancer diagnosis and treatment can affect one's physical and psychological responses, and these responses are potential stressors that can affect one's sleep. In the current literature, there is no well-synthesized evidence on sleep in women with breast cancer, and no paper discusses physical and psychological responses in relation to sleep disturbance. Next slide, please. So to fill this gap, the purpose of this review was to synthesize the sleep literature in young women with breast cancer, discuss physical and psychological responses to breast cancer that may affect sleep in this woman, and highlight gaps in our knowledge and identify the need for interventions to improve sleep outcomes in young women with breast cancer. Next slide, please. So we conducted a narrative review. We searched Ovid Medline, PsycInfo, Embase, and Scopus using the following key search terms. The references were managed by a web-based reference manager called Covidence. Next slide, please. So this is a figure showing the prisma flowchart. There were a total of 466 records after duplicates were removed, and we included a total of 11 studies in this review. Next slide, please. So these are some key findings. The age ranged between 25 and 60 years. This was because some studies included women who are up to 10 years from diagnosis, except for one study which included breast cancer survivors diagnosed at age of 54 years. The rest included women diagnosed with breast cancer at age of 50 or younger. The majority was diagnosed with stage 0 to 3 non-metastatic breast cancer, and a variety of sleep measures were used across studies, including the Pittsburgh Sleep Quality Index, the Insomnia Severity Index, and the Medical Outcomes Study Sleep Scale. Also, some studies used a single question asking about sleep disturbance as well. Next slide, please. So as you can see in this table, all these valid self-report sleep measures incorporate multiple dimensions of sleep. So for example, the Pittsburgh Sleep Quality Index has subscales, including sleep quality, sleep latency, sleep duration, and so on. Next slide, please. Also, the study results show that sleep disturbance level can vary along with cancer treatment. Before adjuvant chemotherapy, the Pittsburgh Sleep Quality Index score was 7.4, indicating poor sleep using the cutoff score of 5. Then immediately after adjuvant chemotherapy, PSQI peaked at 8.9. During the post-treatment survivorship period, about 82% of young women with breast cancer reported insomnia symptoms. One study with 300 young women reported 9.6, a score of 9.6, measured by the Insomnia Severity Index, which indicates subthreshold insomnia. Next slide, please. So sleep disturbance was also compared with other female cancer survivors as well. there was no statistically significant difference in the level of sleep disturbance between older and younger breast cancer survivors before and immediately after surgery. However, young women reported significantly worse sleep disturbance compared to older women during the survivorship phase. And in the first 5 years of survivorship, young women with breast cancer reported significantly worse sleep disturbance than other female cancer survivors. Next slide, please. We also identified factors associated with sleep disturbance. Those factors included greater level of fatigue and depressive symptoms, higher prior level of sleep disturbance in a longitudinal study design, poorly differentiated tumor, not fully employed, less religious, having experienced of treatment-induced menopause, and number of children. Next slide, please. Physical and psychological responses that can be potential stressors affecting sleep include ovarian dysfunction from treatment, uncertainty, changes in body image, and relationships and role changes in young women. Next slide, please. So in conclusion, we found a significant gap in the literature. There was a lack of multidimensional investigation of sleep. We found only one intervention study that improved sleep outcome in young women, which incorporated mindfulness practice. However, there was no valid discussion on underlying mechanism that caused such improvement. Use of a single question can be also problematic in that the results may fail to inform researchers and clinicians which dimension of sleep needs to be targeted in the future. Thus, in my own dissertation work, looking at sleep health in young women with breast cancer, I plan to investigate multidimensional aspects of sleep with additional qualitative data as a foundation for future intervention. Also, I will use valid sleep measures for every dimension of sleep health. Next slide, please. There were several limitations in the current literature. As I described earlier, there were various measures used, including including a single question asking about sleep disturbance. Also, there is lack of longitudinal data. Age varies significantly by including women who are 10 years from diagnosis, which means these women might be experiencing different life course and stressors that will affect sleep in a different way. Next slide, please. The fact that younger and older women had no difference in sleep disturbance during treatment, but older women experienced significantly worse sleep disturbance during survivorship warrants further investigation. One of the possible explanations is that younger breast cancer survivors experience significantly less social support and they're more likely to use maladaptive coping style. More longitudinal data are needed to find a trajectory and predictors of sleep disturbance. Also, the future research should incorporate the multidimensional aspects of sleep using various subjective and objective sleep measures. Lastly, sleep assessment should be part of routine survivorship care in young women with breast cancer. Next slide, please. So these are my references, and I welcome your feedback and comments, any questions.
Mary Ann, you're muted.
Thank you, Yuri. We do not have questions at this time. So, we just got a couple. A comment from Nina, great job, Yuri. Another great presentation. I was wondering, what countries did your research data come from?
All this, they were international, but I don't have that in my hand right now. But I can say that a lot of them were, actually there were a lot of, no, I'm not sure. I think a lot of studies were from the US, but I do have to look at the data. Yeah.
All right. So it looks like that concludes our Q&A. Thank you very much for an
Thank you.
excellent presentation, Yuri. Okay. So now we are going to move on to the two DNP presentations, and we'll start with Esther. It's my pleasure to introduce Esther Pavlovsky as a third-year DNP student. She is the Senior Director for Care Continuum at Mount Sinai Health System in New York. She is responsible there for the health system's post-acute care strategy operations and nursing care management. Esther leads a team of population health nurses and therapists who focus on quality, outcomes, and utilization by patients in the community. Previously, she spent 10 years in post-acute care operations, where she was a regional director and administrator at Premier Home Healthcare. She received her BSN and MSN from NYU and is certified as a Lean Six Sigma Green Belt. Esther's presentation is entitled Evaluation of a Nurse-Led Telephonic COPD Self-Management Program on Healthcare Utilization.
Thank you. Before I get started, I just wanted to acknowledge a few individuals. My advisor, Dr. Tish Knopf, Denise Prince and Dr. Robert Fields from Population Health at Mount Sinai, where I conducted my project, and Dr. Alex Fetterman and Carl Jin that were instrumental in this project's operations. And today I will speak to you about my project. Next slide. Next slide. Chronic obstructive pulmonary disease is a progressive disease which encompasses emphysema and chronic bronchitis. There are an estimated 15.7 million Americans with COPD, and the disease accounts for 40% of age-adjusted deaths in the United States. Of Medicare beneficiaries, 12% had COPD, with majority having one or more comorbidities. In 2010, among US adults, there were over 10 million primary physician visits, 1.5 million emergency department visits, and close to 700,000 hospitalizations with COPD listed as the first diagnosis. In 2010, it was estimated that the US spent approximately $50 billion in direct and indirect costs to treat COPD. COPD is a costly national problem with high mortality and adverse effects on quality of life. Addressing this problem aligns with national efforts to achieve value-based care. Next slide, please. What is value-based care? Value-based care is a reimbursement model that incentivizes quality of care and is designed to reduce costs and improve patient experience. Value-based care highlights the importance of chronic disease management, high-quality outpatient care, and strategies to reduce complications from chronic disease that can lead to high-cost healthcare utilization. In 2010, CMS encouraged providers to organize as accountable care organizations. The qualified entities agree to coordinate care, maintain accountability for quality and cost of care for their attributed beneficiaries, and promote evidence-based care. In 2016, CMS started identifying COPD admissions as preventable. And in 2018, CMS started shifting ACOs into downside risk. This transformation is not only occurring within CMS, but other health plans too. In 2014, Healthcare Transformation Task Force was established by Aetna, Anthem, Blue Cross, Cambria, and Kaiser. The goal was to have 75% of their reimbursements distributed through value-based payment arrangements by 2020. Next slide. Current outpatient treatment for COPD is primarily focused on reactive care, such as transitions of care during acute episodes, which result in ED visits and hospitalizations that are preventable. COPD is a major driver of avoidable healthcare utilization and costs. If the current trajectory continues, the expected cost of COPD will rise to approximately $50 billion in direct costs alone. COPD can impact patients physically with disability, mentally with depression, and socially with relationship burden. Next slide, please. In an observational study of over 200,000 adults who received primary care from an ACO, the prevalence of COPD was 6.9 per thousand. COPD accounted for 34% of annual deaths. The results of this study demonstrated the importance of each ACO understanding the burden of COPD within their population and developing a strategy to reduce COPD exacerbation, slow disease progression, and prevent avoidable healthcare utilization. Next slide. Nurse-driven interventions play a central role in value-based care and ACO strategy to reduce cost of care and improve quality of care for patients with COPD. This aligns well with value-based national healthcare trends that promote prevention, screening, and health promotion for the chronically ill. A nurse-driven COPD self-management program can demonstrate a positive return on investment in the new value-based payment models. It could stem the rising costs of COPD care and eventually reverse the current trends. Large health systems are identifying the need to diversify their revenue streams with shared savings and decrease low CMI admissions, such as those for COPD that produce negative margins. Nurses can help health systems achieve these revenue targets. Next slide. ACOs are required to deliver patient-centered care. Nurses' skill and professional scope contribute to the successful implementation of patient-centered care. Nurses are at the forefront of providing care to patients with COPD along the entire progression of the disease, from prevention to end of life. Nurses review information regarding diagnosis, medication, and treatment plans. Nurses can provide needed follow-up to patients between primary care visits by answering questions, teaching, and assisting with adherence to the treatment plan. Nurses can help coordinate referrals between specialists and other services, such as pulmonary rehab. Nurses promote lifestyle changes, help patients adapt, coordinate care, screen for and address social determinants of health, and educate about the disease. This is why nurses are ideal to conduct this work. Next slide. I conducted a literature review to identify those nursing interventions that could impact COPD utilization. I searched databases such as PubMed and reviewed the GOLD and CDC websites. I limited the search to 2013 to find the most up-to-date information, and further search terms were used as relevant information was identified. Next slide. The Global Initiative for Chronic Obstructive Lung Disease, GOLD, are the existing medical treatment guidelines based on the strongest current scientific evidence and are intended to be used in all clinical settings. The scope of the interventions described range from broad to narrow. The nurse's role is not explicit, but many recommended interventions are nursing-based. We as nurses need to be knowledgeable in the guidelines and ensure that outpatient care being provided are based on these guidelines and coordinate when it is not. We are also able to help with many of the other recommendations within the guidelines, such as those on smoking cessation and vaccination. The GOLD guidelines identified self-management as an intervention that is effective in decreasing hospitalizations and emergency department visits while improving the health status of patients with COPD. The guidelines stated that self-management should promote behavioral change and complement the education provided about the disease and treatment. The GOLD guidelines, though, fail to identify any specific self-management program, so further literature review was done. Next slide. The research on self-management identified many systematic reviews. The reviews found that the program's effective, but the results varied. And this was due to some studies looking at all-cause admissions while others looked at respiratory-related admissions. Heterogeneity of the programs in the literature leaves a substantial gap. All self-management programs included COPD action plans and were not solely education-based. Some articles identified barriers to self-management, and what I found was that telephonic models were effective, knowing that our model would need to be telephonic. Next slide. No single self-management program or model is recommended in the literature, and heterogeneity of the programs can explain the differences in outcomes. Only one study addressed social determinants of health, and not all studies targeted high-risk patients. We knew that our program needed to target high-risk patients and address social determinants and barriers for self-management to be successful. And we needed to review the literature and create our program. Next slide. By completing the review, I identified 3 domains related to self-management. The first domain included medical, which has subcategories which include education on the disease, review of signs and symptoms, medication teaching and reconciliation, and written action plans. The second domain was behavioral, which includes things like smoking cessation, medication adherence, and physical activity. And the third domain was psychosocial, which includes things like anxiety, depression, coping, finances, and social isolation. Next slide. Next slide, please. I conducted my project at Mount Sinai Health System in New York City. And I would like to highlight the ad that Mount Sinai took out over 6 years ago when they first started participating as an ACO. If our beds are filled, it means we failed. The ad speaks to the heart of this project in keeping patients out of the hospital by providing excellent outpatient care and condition management. The project took place within the ACO's care management department. Next slide. A little bit about the opportunity that was found prior to initiating this project. In 2018, we saw a $7 million opportunity due to over $6 million worth of hospitalizations related to COPD and over $1 million spent on COPD-related emergency department visits. In the first quarter of 2019, we already observed over 100 hospitalizations and over 400 ED visits related to COPD. Next slide. The goal of this project was to reduce potentially avoidable hospitalizations and emergency department visits for COPD exacerbation. This project initiated a nursing-led telephonic self-management program for COPD patients. The program's intervention sought to address the medical, behavioral, and social needs of the patient, and the program targeted high-risk COPD patients within the ACO to achieve the highest impact. Next slide, please. Next slide. I use the Donabedian framework. Concepts in the model are structure, process, and outcome. Structure refers to the attributes of the setting. In this case, it includes the value-based contracts and analytical support available to our program. Process refers to the activities associated with giving and receiving care. And in this project, it included things like our telephonic pathway. Outcomes refers to the effect on care on the health status of the patient. And this includes the ability to see utilization post-intervention. The 3 project aims that I will be discussing align with the structure, aim 1, process, aim 2, and outcomes, aim 3, described here. Next slide. Next slide, please. Aim 1 was to create a telephonic COPD self-management program based on review of the literature and an expert panel. Aim 2 was to implement a 50-patient pilot, and aim 3 was to evaluate the program in 2 steps. Next slide, please. Aim 1 was achieved by identifying the medical, behavioral, and psychosocial domains discussed earlier through the literature review. An expert panel of individuals with subject matter expertise, such as primary and secondary authors, ACO and health plan nurse leaders, and care management were engaged. The expert panel provided feedback on the importance, feasibility, and timeliness of the interventions. In the next slide, I will show you a snapshot of what was sent to the experts. The next steps included review of the current state and filling in the gaps, such as creating action plans and improving current assessment and screening tools. An example of a screening tool enhancement that was added was the addition of a PHQ-2 and a GAD-7 with a workflow to refer patients to social work that screened positive. The final step was developing a 6-week pathway, which I will show you a portion of in the upcoming slide. Next slide, please. So here's a sample of what was sent to the expert panel, and we asked them to look at the intervention and assess it for importance, feasibility, and timeliness. And majority of the interventions that required greater than 3-month timeline were related to behavioral change and psychosocial interventions. And in these instances, our nurses had the social workers and care coordinators continue working with the patient beyond their engagement. And the social workers and care coordinators could always re-engage our nurses back onto the care team. Next slide, please. So here's a glimpse of our pathway. And the goal was to decrease variation in intervention. And as you see, for each intervention, there are follow-up actions, desired outcomes, and care plan opportunities. Next slide. Aim 2 was achieved by working with Epic to develop patient lists for us with additional EMR data that can be used to risk stratify the COPD population. Ultimately, we enrolled 50 patients into our pilot at the end of last year. Next slide, please. Aim 3, evaluating the program, was completed in 2 steps. The first was collecting process outcome data through weekly meetings with the nurses involved in the pilot. The nurses provided qualitative feedback on perceived barriers and successes to implementing the pathway. This feedback was used to improve and enhance the current process presented. The second evaluation on healthcare outcomes and utilization will take place at a later time. This will include engaging our analytics team to collect hospitalization data and ED visits for the 12 months prior to the intervention, during the intervention, and at 3, 6, and 12 months after the intervention. This can help facilitate a pre-post test. Due to the timeframe of this project, utilization data will be made available later. And in the next slide, I will share baseline patient data with you. Next slide. So 70% of participants were 75 years of age or older. 64% of participants were female. Black and Hispanic patients comprised 50% of the ethnic backgrounds of participants, and the most prevalent comorbidity was hypertension. Based on the 2020 GOLD guidelines published in 2019, only 56% of prescribed respiratory-related medications for the 50 patients conformed to the GOLD pharmacological recommendations. Bronchodilators were prescribed in 72% of patients, and 44% of patients had no documentation found that a spirometry was performed. Next slide, please. Some additional outcome-related results include the enhancement of EPIC. This allowed us to automate tasks and targets associated with the pathway. The tasks have a corresponding due date based on the pathway, and tasks that are required to be iterative are set to be recurring based on best practices. Another enhancement was creating new patient-centered care plans, as at the beginning of this project, we were using out-of-the-box EPIC care plans that were insufficient. We also translated our patient-facing materials into Spanish. As part of this project, a dashboard was built that would collect utilization data post-program graduation. Working with our analytics team, we will be able to track longitudinal utilization for patients that are enrolled in our program. And this data could be used to conduct an analysis of our program on healthcare utilization. Next slide. And here's an example of what was submitted to have built in Epic. For example, a recurring task that the nurses will be asked to complete each week with the patient is review of the action plan. The automation will decrease variation within our program, which will assist in ongoing quality improvement efforts. Next slide. There are a number of limitations to this project. The first was around data collection, since we used multiple sources and documentation was not standardized. The second is attrition bias, which could occur in a few ways. First, a patient could drop from our attribution. Second, could result from patient death. And third could be from a patient's refusal to continue to participate in our program at any time. Another limitation is selection bias. Patients that agree to participate in the program might be different than those that do not. Patients enrolled in the program might be more motivated to change behaviors and improve their health than those that do not enroll. The last limitation is on program evaluation. We will likely conduct a simple pre-post, but know that patients that have had prior utilization may have lower future utilization due to a tendency to regress to the mean. It will be difficult to claim all differences as a result of our program. Operationally, it is difficult to conduct controlled before and after because we want to be able to touch as many patients throughout our programs to achieve contract performance. Another consideration to the program evaluation is how to evaluate the interdisciplinary work that is done. As discussed, our nurses refer patients to social services and care coordinators to address barriers to self-management. And further analysis on the impact of interdisciplinary coordination can be beneficial. Next slide. Considering how important addressing psychosocial barriers are to successful self-management programs, I would like to indicate a policy change that can help support patients. Our nurses screen and refer patients to social work and community-based organizations. And future policy needs to address the financial instability of these programs, and this could be done through flexible payment models, reimbursing them for their services, or having ACOs include them in their shared savings model. Next slide. So in conclusion, COPD is an expensive national problem that impacts patients physically, mentally, and socially. Nurse-driven COPD self-management programs can be influential in an ACO strategy to decrease avoidable utilization and costs. Nurses are able to connect patients to resources to help address psychosocial burdens and barriers to self-care. Nurses play a critical role in improving outpatient care for COPD patients and conforming care to GOLD guidelines. Next slide. Thank you. And I'm open to any questions now.
Great job, Esther. Important scholarly work that translates immediately to outcomes and to supporting your organization, and great suggestions for future policy. Okay, our first question is, how did COVID change your project?
So our plan was always to be telephonic, just based on New York State regulations and the ability to have our nurses do home visits. But what we did find was, coming out of COVID, that access was a big issue for our patients. And although we had a perfectly standardized 6-week pathway, we found that the coordination was delayed. And so, we were keeping patients on our services longer until we could make sure that, those that need spirometry are getting their spirometry done. PCP visits are being completed and specialty visits. Unfortunately, there are access issues, also certain testing requiring COVID negative tests prior to being able to get a spirometry. So definitely more coordination that needs to be done now.
We have a comment from Nina. Awesome presentation. We have another question. How difficult would it be to scale up the program that you piloted?
Good question. Yes, so it is limited on the number of patients that any given FTE could touch. And our thoughts are also around scaling it to other disease states. and really trying to touch those high risk patients that are persistent high cost or persistent high utilizers, because that's where you would get your largest impact. Some of the studies did find that when you touch patients that are earlier in their disease, there isn't as much of a change in terms of their utilization or impact on their health outcomes. So, you know, it really is limited to the number of FTEs that you have, but by being efficient and the upgrades that we made in EPIC, we do plan to be able to touch more patients next year.
Okay, great. We have another question. Since you were trying to reduce frequent hospitalizations, did you ever get resistance from hospitals who were trying to earn based on hospitalization claims? I'm not sure if that's supposed to be hospitals or hospitalists. I'm assuming it's hospitals.
So I think for us at Mount Sinai, you know, we are really committed to keeping patients out of the hospital that don't need to be in the hospital. And when you think about removing whether it's COPD or CHF or diabetes, these preventable and avoidable types of diagnoses from coming into the hospital, you could actually increase the number of patients that you bring in that have higher CMIs, and you have more room to bring in patients for surgical procedures, which is a better margin for the hospital. But at the same time, you know, providing really good outpatient care, you could then earn shared savings and bring revenue in that way for doing good condition management. And really you're without increasing or changing the work. So it really kind of just hits your, you know, bottom line, those shared savings dollars.
Excellent point. Do you see a role for a strategy that blends telephonic with in-person encounters to support the higher risk patients?
Yes. I think unfortunately in New York, we are a little challenged with various state regulations. You know, ideally we would want to send our nurses to the home. We are limited there. Another model, which you know, is having practice-based nurses doing this work. So you could bring those patients in and see them as they're seeing their physicians or their specialists. But again, I think operationally, our patients are spread out. You know, we are a very large health system, so a telephonic model is more efficient for us.
Okay, and then just the last question, what helped mitigate the patient attrition from the program?
So, you know, I think that using really good motivational interviewing and getting the patients to engage and buy in for those that enroll, and really explaining to them the benefits that they will have, you know, by completing the program, I think keeps patients involved and participating in our program.
Great, thank you. There's so much more we can say and talk about this project, but we do need to move on. So thank you very much, Esther. Really great job. Okay, so for the next speaker is Ron Yolo, and it's my pleasure to introduce Ron, a final year DNP student. He currently serves as the Chief Nursing Officer at Dignity Health Glendale Memorial Hospital and Health Center in Glendale, California. During his current tenure as a CNO, he and his team were able to achieve a Centers for Medicare and Medicaid Services 5-star and Leapfrog A designation, a first ever for the hospital. He also serves as lead CNO for Common Spirit Health's Southern California Division, Los Angeles area, responsible for integrating nursing care delivery among 6 hospitals. In this role, he collaborates with 5 other chief nursing officers and leads over 8,000 nurses in the provision of high quality, compassionate, and safe patient care. It deserves mentioned that just 1 week ago, Ron was awarded the Population Health Mission Award by the National Population Health Collaborative at Common Spirit Health in recognition of his exceptional humanity, dedication, and kindness as part of the leadership team at a mass vaccination clinic. Ron collaborated with 7 nursing schools to onboard more than 130 nursing students to staff the clinic, and over 20,000 people in vulnerable and underserved communities in Los Angeles County, California, were vaccinated over a period of 5 days. So congratulations. His presentation today is entitled Preventing Hospital Readmission in the Sepsis Patient, a Multimodal Discharge National Framework.
Good morning, everyone, and thank you, Dr. Camilleri, for the introduction. First, I'd like to thank the Scholars Day Committee for this opportunity to present my DNP project today. It is indeed an incredible day for us here at YSN to have this venue to showcase our scholarly work. Thank you, Dr. Camilleri, for the unwavering support that these past 3 years. This project would not have come into fruition without your partnership and collaboration. And also, I'd like to thank Dr. Joan Kearney, who also provided guidance and insight along the way. So thank you both. So my project is entitled Preventing Readmission in the Sepsis Patient, a Multimodal Discharge National Framework. It is a quality improvement initiative conducted at Glendale Memorial Hospital and Health Center. Next slide, please. So sepsis is a life-threatening blood infection that affects about 1 million hospitalized patients in the United States each year. It is the leading cause of readmission and represents about $23.7 billion of the U.S. healthcare spend. The main causes of readmissions include reinfection and ineffective discharge coordination post-hospitalization. Transitions of care interventions from other chronic diseases such as COPD and CHF have proven effective to reduce readmissions. However, a significant gap exists in sepsis-specific discharge interventions to prevent readmissions. Next slide. So sepsis readmission is the #1 cause of hospital readmissions, costing about $10,000 per hospitalization in the United States. So 1 in 5 sepsis survivors are rehospitalized within 30 days. There's an impaired quality of life for survivors and long-term outcomes, such as late mortality, immune dysfunction, secondary infections, and unplanned readmissions that have been reported. The Centers for Medicare and Medicaid Services have several programs aimed at reducing healthcare costs and improving the delivery of patient care. The first one is the Hospital Inpatient Quality Reporting Program, or HIQRP, that was first developed as a result of the Medicare Prescription Drug Improvement Modernization Act of 2003. It is intended to equip consumers with quality of care information to make informed decisions about the healthcare options. It is also intended for hospitals and clinicians to improve the quality of inpatient care provided to all patients. These quality metrics are publicly displayed in the Care Compare website. So the second Centers for Medicare and Medicaid Services program is called the Hospital Readmission Reduction Program, or HRRP. This is a Medicare value-based purchasing program that stemmed out of the Affordable Care Act of 2012. This program encourages hospitals to improve communication and care coordination to better engage patients and caregivers in discharge plans and in turn reduce avoidable readmissions. It supports the national goal of improving health care for Americans by linking payment to the quality of hospital care received. There is a significant burden on our healthcare system in terms of financial, societal, and humanitarian costs. Next slide. So what is a readmission? Readmission is defined as an admission to a hospital within 30 days of discharge from the same or another acute care hospital for any reason. Currently, there are 6 measures under this program. They are heart attack, heart failure, pneumonia, hip and knee surgery, chronic obstructive pulmonary disease, and CABG. Currently, sepsis is not part of the analysis. Next slide. CMS penalizes hospitals up to 3% of their annual reimbursement based on a calculated payment adjustment factor from those 6 measures that I just discussed. It is a 3-year performance period. 1 in 5 Medicare patients are readmitted within 30 days of discharge, resulting in an annual cost of over $26 billion. In the state of California, readmissions cost the state about $500 million a year. Since inception of the Affordable Care Act in 2012, CMS has regained millions in hospital readmission penalties, as you can see in that graph below. Next slide, please. A cross-sectional study of sepsis readmissions from 2008 to 2011 revealed that a third of sepsis survivors in the United States are readmitted. There's a new emphasis that should be directed to sepsis readmissions. Deficiencies in care transitions are a major cause of readmissions. Effective discharge coordination strategies from other chronic diseases have been proven to reduce readmissions, such as COPD and CHF. There are several hospital-driven and nurse-driven interventions, such as education, telehealth, provider follow-up, or patient contact that play a vital role in reducing readmissions. However, the literature does not have an evidence-based comprehensive discharge model or framework available specific to sepsis patients. Next slide, please. So I conducted an organizational SWOT analysis for Glendale Memorial Hospital. So a little bit of a background. We are a 334 community hospital in Glendale, California. We have about 50,000 emergency room visits annually and about 10,000 annual inpatient admissions. We recently merged with Catholic Health Initiatives, and we're now called Common Spirit Health as our parent company. We are present in 21 states, and we care for about 1 in 4 Americans. And that has created a lot of economies of scale as a big organization. We recently received a Leapfrog A and awarded a 5-star Medicare hospital. We have improved our quality, patient safety, and experience scores. We have a highly engaged clinical and medical staff. Some of the weakness, of course, we have those merger uncertainties whenever 2 big companies combine. We have a high Medicaid and high acute care length of stays. We have a high number of community providers, physicians that practice in several different hospitals within the LA area. Some of the opportunities that we've identified is to explore more of post-acute care relationships in the community. Also to really innovate and integrate care delivery models to create efficiencies within division hospitals. And lastly, to increase our commercial payer mix. Some of the threats that we've identified are the continued standardization and consolidation on the division level, and of course, the ever-looming COVID-19 pandemic surges. Next slide, please. So what does sepsis readmission look like at Glendale Memorial Hospital? So in calendar year 2018, we saw sepsis as our #1 index admission with 240 cases. For that same calendar year, we saw sepsis as our #1 DRG for readmission, wherein we had about 50 patients readmitted for that calendar year 2018. Next slide, please. So the overall project goal is to demonstrate a 30-day reduction of readmitted patients previously discharged with a primary sepsis diagnosis through implementation of a multimodal discharge framework. So the first aim was to develop this multimodal discharge framework aimed at reducing sepsis readmission. The second was to implement and evaluate this framework. And the third, to recommend for sustainability and scalability of the discharge framework. Next slide, please. So the first aim was to develop the multimodal discharge framework aimed at reducing sepsis readmissions. And it's centered around a 3-pronged approach. The first approach was a nurse approach, wherein we identified nurse-driven, evidence-based discharge interventions. The second is a patient approach, wherein we develop awareness of sepsis symptoms, prevention, and self-advocacy using a sepsis tool. And the third approach is a combination of both the patient and nurse approach, which is to conduct a structured post-discharge follow-up utilizing 2 different modalities. Next slide, please. So for the nurse approach, we had our sepsis nurse navigators conduct these nurse-driven, evidence-based discharge interventions prior to the patient leaving the hospital. First is ensuring that the patient receive a PCP follow-up within 7 days of discharge, making sure that the discharge instructions are discussed with the patient and also the family members. Effective handoff are given between each caregivers. Medication strategies such as medication education and also medication reconciliation is done prior to discharge, ensuring that high-risk patients for readmissions are identified and flagged in our EHR system. We had a multidisciplinary team of individuals that really focus on these patients on a daily basis to ensure that they receive the proper care post-discharge. And of course, collaborating with our post-acute partners, such as our skilled nursing facilities and long-term care facilities. Next slide, please. So the second approach is the patient approach, wherein we developed awareness of sepsis symptoms to prevent and self-advocate using an expert-validated sepsis tool. Sepsis nurse navigators suggested that this fact sheet was placed in front of where it's easily accessible to patients, such as under refrigerators. Next slide. And so the third approach is a patient and nurse approach, where sepsis nurse navigators conducted a phone or telehealth follow-up consults, utilizing a questionnaire to assess for current health status at specific time points, mainly at 24 hours after discharge, then at 72 hours, 120 hours, at day 7, day 14, and day 28. Next slide, please. So this is a sample of the cross-functional flowchart that was developed for this project. The sepsis nurse navigators were the main process owners for this. They receive a daily list of sepsis patients that are generated from the electronic health record. They review and complete the accountability checklist and maintains ownership of that checklist to ensure that tasks are performed. They then establish a rapport with patients. They go up to the units and introduce themselves and ask if they would be available for a follow-up or a telehealth consult prior to discharge. And then those sepsis nurse navigators also conduct the phone follow-ups to patients or their family members. They then track and record those patient disposition for the program. So we did have the RN care coordinators and also the primary care RNs collaborate with the sepsis nurse navigators, ensuring that all of these tasks are completed prior to discharge. Next slide, please. So aim 2 is to implement and evaluate the framework to reduce readmissions. So we recruited about 75 patients with CMS diagnosis-related group of 870, 871, and 872, discharging to home or to an assisted living facility. We observed these patients for about 6 months, from July to December of 2020. We accessed their patient demographics, their clinical and hospitalization data through our electronic health record. As for the evaluation of this aim, we had a patient and nurse satisfaction survey that was conducted after program participation. The second evaluation was to compare the analysis of baseline and project outcome data. We conducted a retrospective review of the number of sepsis readmissions from 2015 to 2019 using DRG codes 870 to 872 from the same time period, July to December. Next slide, please. This is the year-over-year sepsis readmission rates at our hospital from 2015 to 2019. As you can see, that's an upward trajectory. So we established a baseline readmission rate at 44.2%. Next slide, please. So we had to answer a clinical question: to what extent is there a reduction in the readmission rate of sepsis patients after implementation of a multimodal framework that aims to address quality and operational inefficiencies that might occur during care transitions? So we analyzed 2 variables. The first one is the proportion of sepsis patients who were readmitted within 30 days before implementation of the framework. The second variable was the proportion of sepsis patients who were readmitted within 30 days after implementation of the framework. So both were defined in statistical terms as the number of events of interest divided by the number of trials. Those were measured over known periods of time and were defined as the rates of readmission. We conducted a z-test statistics, and the one-tailed p-value of the z-test statistics was computed for this analysis. Next slide, please. So the results, out of the 75 patients, a total of 6 patients were readmitted during the 6-month period. The observed readmission rate fell to 17.2% after implementation of the framework versus the 44.2% baseline rate, which indicated statistical significance. This reduction of note was 20% greater than the average 30-day all-cause readmission rate among Medicare patients, and also resulted in a large effect size of 27%, which indicated clinical significance. Next slide, please. So at least 95% of patients and nurses self-reported satisfaction with the follow-up procedures. Again, this was after program participation. We asked each patient and nurse to rate their program satisfaction. Next slide, please. So the third aim is to recommend for sustainability and scalability of the framework. We had a lot of successes. The patient and families were extremely receptive towards the follow-up activities. There were a lot of stakeholder engagement from physicians to the nurses and other care teams during the project phase. Some of the limitation and opportunities that we've identified is the decreased inpatient volume due to COVID-19. We did not experience the second surge here in the LA area, at least at our hospital, until December of 2020. So a lot of our volume had gone down. Our ER visits was cut into half. We did, as a lot of the hospitals around the country, stop their elective procedures. So our readmission rate may have been underestimated. Of course, we want to explore the inclusion of skilled nursing facility patients to determine framework robustness and applicability. We only focused on those patients that could, pick up the phone or, set up their iPads to do a telephonic or a telehealth consult. And so we wanted to see if, at the end of this, we could include those patients in skilled nursing facilities to participate. There were also some suggestions about including COVID-19 education during the follow-up consults. Of course, the framework will require some refinement for sustainability, integration, resource and time allocation, and program adjustment here at the hospital. However, these results will also be vetted among the stakeholders for consideration for scalability in the Southern California hospitals and nationally. Next slide, please. This is the footprint of Common Spirit Health. Again, we're present in 21 states. So we're hoping to vet these results in the Southern California division, and hopefully we can expand to these states as feasible. Next slide, please. So implications for healthcare. There was an estimated cost savings of about $700,000 for those patients that were not readmitted during the project phase. There's a substantial value capture opportunity to reduce readmissions with existing resources. This underscores the importance of allocating or dedicating human capital, such as sepsis nurse navigators, to address a significant disease process. The high patient and nurse satisfaction rates highlight the magnitude and value of the model. There's desirability in patient and nurse partnership in navigating through the complexities of the healthcare system. So we found this wherein, we had one dedicated person that the patient could call whenever there's a problem. For instance, they weren't able to fill their medications, or they couldn't get in contact with a specialist for a follow-up appointment. Having that dedicated nurse navigator be that one contact for patients really helped a lot. And finally, this DNP project contributes to the body of knowledge in sepsis care. It provides an evidence-based discharge framework and interventions to prevent hospital readmissions. Next slide, please. Those are my references. Next slide. Next slide. All right.
Okay, great job. And thank you for being so astute as to identify a really overlooked issue in sepsis readmission. Oftentimes systems focus more on where the value-based payments or penalties are and overlook some of these things. And your focus on the patient is, and what's good for the patient, I think is, the way we should all be looking at the world to improve things. I do have a question. I was going to ask you a question. Let's see. Is there a recommended caseload for each sepsis nurse navigator? And could they be utilized across hospitals that are in proximity?
Right. So I'm going to read that again. Is there a recommended caseload for each sepsis nurse navigator, and could they be utilized across hospitals?
Like if you have
Yes.
hospitals close proximity.
Yes, that's a very good question. So currently, we do not have a recommended caseloads for sepsis nurse navigators, since this was such a novel program that we introduced. Our care coordinators usually have about a caseload of 19 to 20 patients, per day. And so I could foresee that sepsis nurse navigators could perhaps, starting out, especially if the program is so new, to perhaps have that in half, to really focus on those patients that really need a navigation. And so, the consults take about 10 to 15 minutes, a day. And so I think having those, caseloads low to start out with, I think will be doable. And I'm not sure, yeah, absolutely. I think they can be utilized across hospitals if you have them. If you have a centralized, a facility or a centralized location where you could call and have access to, EHR records from each hospital, I think that will be, that would work out.
Okay, great. What do you foresee as a barrier to the scalability of your project, especially in this uncertain pandemic environment?
So I think dollars is definitely something that we all have to, look at, right? Everything we do in healthcare is tied to the dollars. FTE onboarding and reductions are always, in mind, and I think that we have to be cognizant of where we're at as an organization in terms of volume. A lot of the hospitals around the country have experienced a decrease in their surgeries and their ER visits, and so I think that we have to be very strategic on how we approach this topic and this programs in order to best deliver the care that we can for our patients.
Given the dollars, what other members of the team could help the scalability?
What other members of the team could help scalability? Okay, so I think that physicians have a lot, or physician or our advanced practice providers have a lot of stake in this as well. Their partnership. We so happy and thankful that our physicians and our advanced practice providers here at the hospital were highly engaged when I first approached them with this project. And so I think that with their partnership, this can be definitely scalable. And if they have we have their buy-in, especially the primary care physicians, this will be a great project to scale to other organizations.
Okay, that concludes our question and answer session and your presentation. Thank you very much, Ron. And now Dr. Kearney, Chair of the DNP Division, will have some closing remarks.
So I feel like the morning flew by. Everything was so interesting. I was riveted to everybody's presentations. I'll just be saying a few very brief words as we transition from this portion of our Scholars Day event to our poster session. So first of all, we want to thank all our wonderful presenters today for their outstanding presentations. A big thank you to our keynote speaker, Dr. LaRon Nelson, our postdoctoral fellow, Dr. Abigail Wilpers, PhD student Yuri Wang, DNP student Esther Pavlovsky, and our DNP student Ron Yolo. I think we can all agree Each of you has truly upheld the Scholars Day tradition of excellence at YSN as you shared your impressive scholarship and science with us. Thank you again for that. We also want to thank our attendees, our faculty and students, and of course our guests. It's always wonderful to have a broad community of scholars come together to share the important work that continues to move us forward. So thank you all. It's great to see how many of you are here today. I have a couple of announcements before we move to our next session. Please know that our doctoral programs have upcoming information sessions planned. The PhD program will be hosting a virtual information session on Wednesday, April 21st from 9 to 10 a.m. Eastern Standard Time. You can find the invitation for that on the YSN Scholars Day website. For the DNP programs, both the Healthcare Leadership Systems and Policy program, as well as our clinical program, you will find information for these sessions on the YSN DNP website as they are scheduled throughout the year starting in early to midsummer. And now, we would like to invite you to join us for our virtual poster session, which comprises the rich and varied work of our community of scholars. You will find the link to this session in our chat box. Thank you all again and enjoy the posters.